move on. So we're going to move right along to our local rock star. That's what he was called this morning. Joshua Tepper said, Dr. Ross Baker is a rock star. In fact, searched high and low to try and find some quotes from you. He's actually got several of them. He keeps them all in reserve. Now, our conference program tells us that Dr. Baker is a professor at the Institute of Health Policy, Management and Evaluation, University of Toronto, a role that he's had for some time. I'm also pleased to advise, though, that Ross is an eminent author, with two of his better known publications being High Performing Healthcare Systems, Quality by Design, and High Performing Healthcare Organisations. It just fits with this whole conference, doesn't it? In fact, you could also say the conference has been fit around these particular publications and Dr. Baker's specialist topic. Rumour has it that Ross's next publication will include activities within the MidCentral district. We're yet to confirm that, I think. Is that right, Ross? Yet to confirm it, yes. We haven't talked, no. Some interesting facts about Ross. He has led or co-led studies of adverse events. He's published a number of articles on patient safety. He's developed one of the first balanced scorecards in healthcare, and he's got several awards across education and research. Very well founded, very well round based as well. Most importantly from our perspective today is that he's looked at quality and patient safety from all angles. So here's just some examples of them. Developed a toolkit for governors, created the Canadian Patient Safety Institute, and a research team that has examined patient safety in home care settings. So different views of our patient environment, our patient experience. So Ross and his lovely wife Suzanne have visited, they're here in New Zealand now, and they have visited once before. I believe it was about 2005. And of course, when you get a chance to come to New Zealand, you visit Milford Sound. I think you walk the Routeburn track. And when he said to people, so where should I go next? They said Palmerston North. So he's had to wait 10 years for us to conveniently have a conference so that he could get to see his number 2 site in New Zealand. Ladies and gentlemen, let's all put your hands together and welcome Dr. Ross Baker.
Thank you for that, and it is a true pleasure to be back in New Zealand and to be in Palmerston North. These issues about system transformation and building a system that's better fit for patients and for providers and for our broader society are issues that are really engaging people around the world. And we share common challenges, we share common opportunities. And so it's been a great pleasure for me to hear about the work that you're doing here, work elsewhere in New Zealand. And you know, I think we have a lot to learn from each other. And so my talk today is really intended to sort of focus in on this issue of system transformation. And to my lessons for you, although I think you probably realize a lot of this, are to see that the work is not only difficult, but it's something that we need to address more systematically to develop the capability in our system to really make these changes happen. And so I'll talk about what I think some of the critical issues are and some of the approaches that we have seen in Canada or elsewhere that I think have been useful in sort of building this capability to make a difference. This is not news to you that we're in a crisis and that we have to do something significantly different. The status quo is no longer an option. And it's a perfect storm because it deals with changes in disease epidemiology and population needs, increasing technology, changes in the workforce, and the fact that in all our societies, people are really maxed out in what they can spend on healthcare. And in New Zealand and Canada, the money that goes to healthcare doesn't go to other sorts of social services. And we know the broader determinants of health really focus not on healthcare, but on education and environment and creating a society where people get the kinds of opportunities that are going to give them the opportunity to be healthy citizens. So our job as citizens, our jobs as members of this complex but important system to provide care to population is really to figure out, within the context of the perfect storm, how do we move forward? And there are a number of questions, and these are my 3 questions. How do we improve quality and safety? How do we engage care providers and patients to use current resources more effectively? And how do we link care across the system to really integrate that care and to create better outcomes and improve patient experiences? And who would disagree that these are the critical issues facing us? But having the questions doesn't really give us necessarily the path forward to that. And so many people, like you here in New Zealand and in Canada and elsewhere, have really been trying to figure out what the strategies are to move forward. And like Joshua this morning, I'm a big fan of Helen Bevan and her really thoughtful work. And the NHS is a system that moved mountains really over the last 15 years. It moved from a system that really struggled to emerge as a highly integrated, highly effective system, and they made enormous changes. And then the government decided that they would undo much of the things that they achieved and really remove some of the capability for that system to improve. And so the last few years, as they've taken money out, I think they've really struggled to maintain the gains that they had and had achieved over the previous decade. But we all face challenges. We all face challenges of improving care, improving outcomes, improving the patient experience while not increasing the costs. So I want to talk a little bit about the Ontario experience because, like you, we've been thinking about this, and Joshua talked about our ministry's efforts to create a plan to move forward. And the plan has many parts to it, starting with legislation which says that every part of the system has a responsibility for quality of care and ensuring that we set and meet quality goals. So we have a strong strategic direction, we have strong accountabilities, we're realigning funding, we're creating efforts to integrate care across primary specialty and community care providers. We're building the evidence-based pathways, much as you are here with the map of medicine, and we're strengthening parts of the system which frankly have not been as strong as they need to be to provide the kind of system-wide care. So strengthening home-based care, community-based care, and primary care in our system. So that's great. I guess we've solved that problem. We know exactly what to do. Now we can all go off and celebrate that we've done our job, right? The path is clear. And we just need to tell people they need to get on with the job. Well, I'm finished. Yeah, a bit of it. Well, actually, there's a second part to that, and the second part is it's not so easy, and there's many people in the system who really don't have a clue about how, everybody agrees that change is necessary, as long as it's not them changing, right? Somebody else has to change, and we don't really understand this piece about moving from brilliant strategy to on-the-ground change. That's the difficulty, is linking the execution with the strategy. And Sun Tzu is a Chinese military strategist, but I think the metaphor fits healthcare. We can have great ideas, great slogans, great plans that get put into wonderful PowerPoint presentations and very glossy brochures, but that doesn't help in the GP clinic or in the hospital or in the home care service to make sure that these plans turn into reality. So we have to think about this as a long-term journey and as a strategy that moves us from the current reality into something new, something better, something sustainable for our healthcare system. And this diagram, which I shamelessly stole from the Baldrige people. The Baldrige Award was created in the United States 20 years ago as an award for excellence in private business. And then they discovered that the people that were using the Baldrige criteria most often of any aspect, any part of the economy were the healthcare people. They faced the biggest challenge. So they created a new category for healthcare organizations, and they've given a dozen or more Baldrige Awards for excellent performance and strategies to improve performance in healthcare. And Baldrige says It is a journey, and we need a roadmap for that journey. It's not just enough to give people the idea that we want different outcomes. It goes through various stages, which you see sort of outlined on this slide, starting from a sort of a compliance status quo agenda, and then moving into project-based activity. But then the real change, the real impact comes as we start to link those projects together, try to figure out how those projects integrate into the critical issues, how to connect people in different parts of the system, and then how to build something that has a sustainable path forward. And in Ontario, you can see I put this little box at the bottom of it, because I think we're still very much in maybe the latter parts of stage one. We're still in this project-oriented mentality where we think that getting a lot of project activity is going to give us a lot of results. And it only gives us the sort of glimmers of what we need to do. So my message to you today is to think more systematically, to think about this as a system initiative, not necessarily only as an initiative that happens within various teams or across teams in the system. And again, Helen Bevan has helped us think about this, because she said if you want to move the system, you want to transform the ways in which we provide care, we need to now be thinking about capability and capacity. And capability is the measure at an individual level of nurses, doctors, pharmacists, managers, to understand the knowledge and the skills necessary to change frontline practice and change the systems that surround frontline practitioners to provide higher quality of care. But it's not just an individual skill, it's a system component as well. So capacity is the notion of having enough people across the system to actually make a difference. And in Canada, we have overinvested in the acute care environments with people who can do this, and underinvested in community and primary care environments. So the work that you're doing in New Zealand, which I think is much more balanced across the system, is a model for us as well. So building the capacity and capability of people to make a difference. And what's the evidence that this actually is important? Well, the evidence comes from some of the case studies work that we've done looking at the high-performing healthcare systems. And the conclusion to that work, which we talked about in some detail yesterday, was that there's three elements, three critical types of things that need to happen in a healthcare system to really make it high-performing. The first is around leadership and strategy, having the leaders who have a system view and understand what needs to happen in the system, and then have a strategy that's aligned with that, with core activities and across leaders in the system to make it happen. So that's absolutely critical at the apex. And then the second piece is designing a system that fits the needs of the population of the 21st century, that has primary care at the center, that has patients engaged in that activity, that integrates care across the different sectors, across the different silos that exist in many different systems, and that engages professionals working together in teams at the microsystem level, at the organizational level, and across organizations. And then the third piece of this is what I call capability building, building the resources in the people, in the information systems, in the patients that we engage to make a difference in healthcare. And I'm going to focus on that last piece, that capability building. And one of the places that has been very influential for us in Ontario and really around the world is Intermountain Healthcare, and you see Dr. Brent James standing very humbly in his white coat. One of the key champions of quality improvement in the world, and working now for more than 25 years at Intermountain to build a structure, an information system, but also a capability to take that information, take the knowledge about what works, and turn it into effective practice within Intermountain. And I talked about this a little yesterday, so I won't repeat some of that. But I think the critical piece of that was to develop a shared understanding, a shared language, a shared mental model of how to improve care in Intermountain that went from the ICUs in the large teaching hospitals to the family practice clinics in the community, so that clinicians, from different backgrounds, and managers at senior levels and middle levels and frontline levels could have the conversation about the tools, the methods, the objectives in the same language. And you don't become a leader in Intermountain at any one of those levels unless you have taken their 21-day advanced training program and learned the skills, learned the application of that skills, and worked with others to do that. As you can see, more than 2,000 people have graduated. Each one of those does a project. They're mentored by leaders within the system, and they've developed this core capability in the system to take issues and then to disseminate the work on that issues throughout the system that's serving more than 1 million people. My other example, and different than the ones I used yesterday, is Cincinnati Childrens. Dr. Uma Kotagal, who's a neonatologist and Senior Vice President responsible for health system transformation at Cincinnati Childrens, has built this enormously productive enterprise in Cincinnati in a teaching facility, a big research facility, but one that's focused on improving care for patients and securing the best possible outcomes. So they have a sort of national and international reputation for their work in patient safety, their work to build high reliability systems, and their efforts to engage staff at all parts of the organization to make that happen. But what makes this something that really engages people and creates the engine for change within Cincinnati Children's is this opportunity for clinicians and other staff to become engaged in what they call I squared, S squared. I don't think they spend a lot of time thinking about the title of this course, right? The Intermediate Improvement Science Series, I squared, S squared, which again is a intensive experience grounded in a project, mentored by key leaders within the organization, having an impact on people and on the organization through the projects that they do. And I had an opportunity, the first time I visited Cincinnati Children's about 6 years ago, I was invited for a research project, and I went early because they have these quarterly meetings where they take all the projects in the organization and they report them out. And the senior leadership, many of the clinicians gather in the main auditorium of Cincinnati Children's, and Tom Nolan and Lloyd Provost, who are two of the sort of mentors and wizards of quality improvement, come and they listen to this and they provide feedback, and the senior leaders were there. And I thought I'd gone to Mars, because for 20 years or so I've had these conversations with knowledgeable people around improvement skills, and you share a language, you share an understanding. But to be in a place where everybody understood that, and where control chart after control chart was put up on slides, and people talked about it in sophisticated fashion, and nobody put their hand up and asked what the p-value was on those results, because that was the wrong question, but it's a typical question in those large research environments, right? So I thought, wow, here's a true measure of culture. Everybody understands the problems in the same way. The senior leaders, the senior clinicians are in the room having this conversation, and they're asking, how do we now move our results to a different level? That's a sign of cultural change. It's a sign of making a difference. And behind that is this amazing program that they put together. So I'm going to say a few words about Canada, just so that you know that we're not as well off in most of our facilities as those two places, Intermountain and Cincinnati Children's. Some of our leaders don't see the value of quality improvement, and I had a conversation a year ago with somebody who had been a CEO who said, so why should we invest more money in training programs? Why would we do this? Don't we already know how to do quality improvement? And I said, I don't think so, actually. I don't think there's enough people who really understand this, because if we want to make a difference at the front lines, we not only have to have people who are excellent clinicians, who have the knowledge and skill to do their work as physicians, nurses, and therapists, but who can build into that knowledge an understanding of the tools and methods to examine current practice, to identify ideas that will give us better outcomes from that practice, and then to work in a team setting to test out those changes, to see the results of those changes, and to make improvements and sustain improvements over the time. So my view is that the only path forward that's sustainable is one where we give people the skills to link to their clinical and scientific knowledge to make change happen in these organizations. And we did a bit of work now in 2007, so it's only 7 years ago, where we went out and surveyed all the hospitals in Ontario, roughly 140 of them. We got about 100 responses. And it was really, I have to say, quite disturbing to see the underinvestment in improvement skills. There has been I think in our environment for a long time, a sense that a mark of success in healthcare organizations is the percentage of their budget they spend on frontline staff. And so that every dollar that's spent on nursing managers, on decision support people, on quality improvement support is seen as a non-productive part of the unit, sort of a necessary overhead. And my personal view of that is that is wrong. Not that we shouldn't be investing in frontline staff, but at the end of the day, if we want to make those staff as productive as possible, we need to help them understand how to make the changes necessary in their environment. So that was 2007. Joshua Tepper and myself and a few other people convinced the Ministry of Health that there was a different way forward besides sort of stressing the system to try to create better results. And that different way forward was to follow the path of Intermountain and Cincinnati Childrens and many other organizations who've seen this need to build local capacity to make change. And so we've created this program which we call IDEAS, Improving and Driving Excellence Across Sectors. I did not make that name up, but it's kind of clever because as soon as you ask if anybody has any good ideas, it sort of starts people chuckling about this. But anyway, we're building on Intermountain's experience. We have a short introductory 2-day program, and then we have a 9-day program, and we're recruiting teams from within organizations and across organizations in intersectoral work, trying to build knowledge about how to improve care within specific pathways, COPD, CHF, and other pathways which are a focus for our work in Ontario, and then for high needs, complex patients whose care needs to be better integrated between community, primary care, and hospital-based settings. And so the goal of this is to provide state-of-the-art quality improvement training. We've recruited the best people we can find locally and internationally to help design the program. And these teams bring individual projects with them and work on this over a 5-month period with 9 in-class days, and then between session opportunities to work with coaches, quality improvement coaches, data coaches, to make a difference. And we've had, to date, we're at the end of the 2nd year, we've had close to 200 people graduate from the IDEAS curriculum, and now more than 1,500 graduate from the introductory curriculum, which we're doing in partnership with the 6 medical schools across the province. So that's great. So that's a start. And I get the opportunity to see all these cohorts graduate and to listen to their projects and to hear what they're doing. And it's really encouraging to see this work go forward. But the question is that enough? Developing this individual skill sets. And I think I've already sort of indicated to you that I think it now needs to be brought into a system perspective. How do we create a system that values these people, uses them wisely, and supports their work? So most quality improvement initiatives run a success rate of somewhere between 30 and 40% of the projects that are commissioned. And the question is that the best we can do? Or if we wrapped resources around people and made this more of an organizational focus rather than a team focus, could we do better? So a couple of weeks ago, actually, thinking about what I was going to be doing here in Palmerston North, I recruited 12 knowledgeable quality leaders at mostly senior levels within organizations in Ontario to ask them, so given what we've achieved so far, what other capabilities do we need to improve on our current record of success? How can we maximize our investment in the capability and capacity of these people? And I gave them a list of issues Some related to the nature of the project, some related to the skills of people on the teams, some related to the organizational resources provided to these teams, just to try to figure out, so how do we goose this to sort of maximize the value of our investment in quality improvement? And I hit a chord, so maybe I was talking to people I knew and liked and who thought the same way I did. It was only 12 people, but they came back and they said, yeah, these are critical issues on a 7-point scale. They're pretty close to, everybody said, important or very important. And then I asked them a second question, so how well are you performing in your organization on these issues? And as you can see, there was a huge gap there between the issues where people said, yeah, this is important, and we're still trying to figure out how to do this. So I want to pick from that a number of issues, because I suspect, I don't have any data to this, but I suspect that these are issues that bedevil people in many different environments. And so thinking about it systematically is one way to ensure that as we invest in the system transformation efforts, which basically turn out, we talk about system transformation, but all the system transformation issues are local projects, engaging people in local activities to make a difference. So how do we now extract the value from that? So the 5 issues, one has to do with data, second has to do with executive sponsorship, linking these teams to leaders within organizations. The third is thinking hard about the nature of these teams, the interprofessional collaboration that's necessary to make these teams work. The fourth is the issue of senior leadership in organizations. Do senior leaders have the skills necessary to do this? And lastly, this challenging issue, which you're working on as well, coordinating improvement across organizational boundaries. So let me start with the data issue. Data is everywhere in quality improvement, right? Plan, do, study, act, right? You need data to figure out what problems you're going to work on. You need data to figure out what kind of progress you're making in improving the current processes that you're working on. You need data on balancing measures to make sure that the changes that you're putting in place don't have unintended negative consequences, right? It's all over the place. And so one of the experiences we've had in the day 9 of the advanced program in ideas is that teams get up and they present their work, and it's all interesting, and some of it is really good, and some of it is clear that people are struggling. And what do they struggle with most? Data. Real-time or close to real-time data on the clinical processes, the patient experiences that they're trying to change. And so there's something wrong with this picture, right? We're saying these are system issues, these are high priorities for us. We've committed doctors and nurses and quality improvement people to work on these processes, and then they say to us, we couldn't get the data to figure out what we were doing, right? What's wrong with that picture, right? Because at the same time that we're investing in quality improvement, we're also investing incredible resources in information systems. But those information systems are not talking to the people doing the quality improvement work, right? So there seems to be a major disconnect going on. So we've been struggling with this issue for a while, and the answers are going to be, I think, challenging in some areas, but in other areas they're not so challenging. So this is a control chart from a team that presented last month to the 5th cohort graduating in ideas, and they were working on the hip fracture pathway. We call it quality-based procedures, the hip fracture pathway. And it was a team in northwest of Toronto, and this part of the project focused on reducing the length of stay for hip fracture patients, which was at 13 days, which is way off the scale, for hip fracture, right? And they knew that, and because the funding is changing, the hospital was quite vulnerable now to lose all sorts of resources if they couldn't figure out how to convince the doctors and the nurses and the therapists to change the pathway of care and the link to the rehab facilities or the home care that would take these patients on discharge. So they did a number of things. None of this is new. Education, process mapping. They developed a checklist to ensure that they had all the information and the patient was going to be ready to go at a certain period of time. They launched the checklist. They put it into a consolidated electronic report. They identified access and flow people who could help to monitor this over time. It's kind of standard quality improvement stuff. And then they said the thing that everybody's jaw dropped on. And the organization decided, because this was really important, they were going to give us somebody who was available to collect the data that we needed on an ongoing basis. Now, on the one hand, I'm ashamed to have to be saying that this wasn't something that occurred to people, but it was an unusual event, right? For them to say, wow, the organization built a resource set around us to make this happen. So I think we need to think more systematically about the resources that teams need. One of it's data, but there's other kinds of skills as well, and I'll come back to that a little later. So executive sponsorship. Teams have a big responsibility to get in and do the difficult work of understanding how to improve the care in different settings. And as you know, there are some things that they can do that are easy to do, right, that don't require a lot of permission. But there are other things that do require other people to get involved. And some of them are fairly straightforward, or apparently fairly straightforward, but also bemuddling and frustrating. And one of the issues we face, Canadian hospitals have developed very elaborate strategies for dealing with changes in forms. I don't know if that's a pattern around the world, but if you want to change a form in some committee, you have to go through 3 or 4 different review processes, right? And how long does it take? Months. It takes months. So we want to improve discharge, and we're going to simplify this and create a discharge checklist. Oh, sorry, folks, that's a form. You can't use that until the forms committee says that fits the, right? Are you kidding me? Right? Plan, do, study, act. We're bright, capable clinicians working on these problems are told they have to wait 3 months before their sample discharge checklist can be used? I don't think that's right. So what's the answer to that? Well, we need forms committees. I'm not a radical here. I think we need to ensure that the things that are done right are not going to endanger safety and so forth. But what we also need is executive sponsors who can say, you know what? There's a quality improvement project. I've looked at the form. You know, we've reviewed it. We're going to let them use this, right? We're going to give them a buy on this. So the executive sponsor is responsible for ensuring that the team can actually do the work that they're trying to do and removing these obstacles that might come up. Now, this turns out it's not only a problem in healthcare. This notion of teams that are trying to do things that don't have a connection to the organization that allows them the flexibility to make some of these short-term changes. That's a problem in many places, and there was one study we found of defense industry projects, people going out spending millions of dollars building new defense hardware, and they discovered that the teams that failed were the teams that were not connected to the organizational leadership to allow them to do the things necessary to develop that. So, you know, if it's important for defense, I think it's also important for healthcare. So I won't spend a lot of time on this, but I think you can look at this. The role of the executive sponsor, for some people, for some leaders at a middle management and senior management level, this is a natural kind of thing to do. They already work this way, working with their teams, understanding what the teams are doing, what their frustrations are, coaching them, removing barriers, all these kinds of appropriate activities to help the teams make a difference. But for others, it's not. For others, this is a new way of working. And so we've now developed a program in Ideas, an executive sponsor program. So every team that comes forward has to name an executive sponsor. And then the executive sponsors are strongly encouraged to participate in a couple of webinars where we talk about the role of the executive sponsor. We have a couple of really successful executive sponsors sharing tips about what they did to work with their teams when the teams hit the wall and so forth. It seems really obvious, really simple, and many people don't do it. Third issue, interprofessional teams. And I have this lovely quote which I found from Peter Pronovost, who's the Johns Hopkins patient safety expert, about his insights about teamwork, team communication as being a critical piece of what they're doing. Most quality improvement teams are interprofessional teams. And so they have to learn how to work, how to communicate, how to understand the nursing perspective, the medical perspective, the perspective of the RT, and how to work together to create a common vision, a common solution. Okay, so we all recognize that. But many of the changes that teams make to make a difference actually go to some fundamental questions about how we do communication, how we do understanding progress of patients within healthcare settings. So discharge processes often center on creating more effective communication among team members, and one of the typical ways to do that is to create interprofessional rounds. So how hard could that be? Interprofessional rounds in a hospital setting. Well, for many people who've practiced for 20 or more years doing profession-specific rounds, that's like the earthquake in Christchurch, right? You're kidding me. Are you joking? I don't have time to do that, right? So we're dealing with some fundamental changes in practice here that require people to rethink the way in which they actually approach these issues. And that is a skill set that is, I think, still underdeveloped. So I was chatting with a friend of mine who does a lot of work in interprofessional communication and teamwork, and who's now working with us in ideas, helping to do some of the teaching. I said, so how often do you see teams struggle with interprofessional issues as they're trying to do their quality improvement projects? And she looked at me as if I was from Mars. She said, are you kidding me? She says, a third or more of these teams have major issues where they have to negotiate a new understanding about how we're going to work together if we're going to be successful. Senior leadership roles. I've already said, we've created a great strategy, a great sort of, if you will, framework for improving quality in Ontario. We have legislation, which is appropriately named Excellent Care for All Act. All organizations are required to do annual quality improvement plans. There were more than 1,000 of them created and submitted a month ago. The Minister of Health has an action agenda. He's identified the strategic issues. So I guess, that's all that senior leaders need to worry about, is to take those plans and bring them back and sort of share them with the organization. But no, I don't think that's right. I mean, I think the role of senior leaders is to figure out how to manage the strategic agenda, how to focus in on that. And Murray mentioned the fact that we've done some work on governance. It's still an issue in many organizations to get a strategic focus on a manageable number of issues that the organization is trying to deal with at any one time. And because we have limited capability to deal with these kinds of change issues, that makes it particularly challenging in organizations. So if you have 30 strategic objectives, right? In most organizations, it's impossible to do meaningful work on 30 strategic objectives. What the staff do is try to guess or ask people who they think are in the know. So there's 30 things here, which ones should we work on, right? Because we don't have time to work on 30 things, right? So part of this is really reframing the work of system leaders. And Jim Anderson, who was the CEO at Cincinnati Childrens for more than a decade and who helped to oversee a lot of the frontline changes, has this, I think, really marvelous quote that talks about what the essence of the senior leadership role. The senior leader doesn't do the job. The senior leader creates an environment where it's possible for frontline teams to do this work, to make a difference within the organization. Each of us has an obligation to the other to make excellence habitual, right? Again, pulling out the kind of cultural issues that underlie this. So senior leaders have a number of critical roles. I've already talked about this, identifying and focusing on key quality goals, returning to those at a regular basis, right? So it's not enough to announce them once. It's this habitual over-communication so that people understand what it is that leadership is focused on. Ron Heifetz, the Harvard Scholar of Leadership, says the currency of leadership is attention. The currency of leadership is attention, which has been translated in many ways, one of which is, what interests my boss fascinates me, right? So leaders send a message, right? They send direct messages and they send indirect messages. You look at the agenda of a leader, you're looking at a list of things that leader says are really important for the organization. And we have to keep that in mind. And I think effective senior leaders are very conscious of not only the explicit messages, but the implicit messages that they send. And they pay attention to the supporting executive sponsors, supporting teams, hearing the reports of teams, making the reports of teams a high-profile event, not something that's buried within the organization, so that everybody's reminded that there's not only the work that we're doing today, seeing patients, providing care, but the work that we're doing to build a different system that's going to allow us to move effectively into the future. And Heifetz, Ron Heifetz is also responsible for this work, which Joshua talked about yesterday, about technical and adaptive change. And the role of leaders is to understand not only the technical issues that are necessary to change practice, but the adaptive challenges that people face as they're being asked to do things differently, things that they sometimes have come very attached to, and over time to realize that they need to be helped, they need to be coached, they need to understand sometimes why it's important to do this, and how we can support people to do it. So technical and adaptive work. And then the fifth challenge is this challenge which you are grappling with in a major way, the challenge of working across boundaries to create integrated care. And one of the CEOs of one of the Ontario regions said to me, he said, Ross, he says, we have lots of great organizational leaders. We have very few system leaders. And our system leaders don't get the respect sometimes that the organizational leaders get. So we're sending a message on that. At the same time we say that integrating care is important, we're also saying, and the biggest rewards go to people who are the heads of the organizations. So integration is a challenge, but we need to think about this. I talked about Jönköping County yesterday and the role of Esther. The idea of putting the patient at the center helps to create a common vision about what we all need to do regardless of what our current role is. We just finished a set of work that builds on a PhD thesis by one of my students, Jenna Evans, and now looking at some of these integrated care initiatives in Ontario. And we, again, returning to this idea of technical and adaptive change. And the interviews with people working on health links, these informal initiatives trying to restructure care for complex patients in the community and in the hospital. And one of the really thoughtful people we talked to had this quote where she said, integrated care is as much a mindset as models, processes, tools. It requires new ways of thinking and behavior. It's not just our project, HealthLinks, it's not just a project, it's a way of being. So this is the challenge we face. The challenge is, at the end of the day, system transformation is a series of projects that involves people at the front lines and elsewhere in our healthcare systems. But if we're going to be successful, it has to be more than just a collection of projects. It has to be a strategic approach where we engage people in their roles across the organization, from senior leaders through executive sponsors at the middle levels of the organization, through frontline teams. We give people the skills necessary to do this, and then we support them. We make them feel like this is an important part of their work. We help them when the work isn't going well, and we give them the tools and the support necessary to hopefully bring us to a much higher level of success. And in the long run, although we rely a lot in our system on compliance and accountability, my view is that accountability without capability is defeating, right? You put people into an impossible situation. You ask them to do things, and then you don't support them to do that. And there's only three outcomes when you have accountability without capability. One is denial. These data are wrong. No, this isn't our current performance. No, this couldn't possibly be right, right? That doesn't usually last very long. The second is deception. There's no way we can make this target. We have to reclassify some of these patients so they're not in this group that we're now dealing with. How do we do that? What's the additional coding we can do to make sure that they're not counted in this group? I don't know if that happens here, but it certainly happens in our place. And the third is desertion. All of these are corrosive kind of behaviors, right? We're encouraging people to do things that really undermine their commitment to the system, to deny that the data are right, to deceive us on the nature of the results that they're collecting, or to say in the end, I can't do this, I need to go somewhere else, right? Losing that skill and that capability. So we need to move to a different path. We need to see this as a system investment in frontline staff, in organizations as a whole, thinking about these questions. Do we have a strategy around improvement capability? Does it move beyond individual skill development to think about what the organization as a whole needs, providing people with the tools, the knowledge, the coaching to make this? Will we support people in applying these methods over time? Will we give them feedback on what they're doing well, what they're not doing well? Does the program that we develop, many people have programs, does that program actually give us the skills, the opportunity to provide sufficient scope and scale to make the differences? We're talking about major change in our system. We're talking not just about isolated individual microsystems that now have to change the ways in which they're identifying patients. We're talking about major changes in practice. How are we supporting these teams to make those changes? Are we giving them the data, the support, the coaching on an ongoing basis? And are we developing not only the frontline teams, but the executive sponsors and the senior leaders to make a difference? I hope that what you're learning and doing this work is going to be spread across New Zealand, across the world. I've heard some really encouraging examples in the couple of days I've been here. I think we're beginning to grapple with this, and then we're now sort of putting together the renewal grant application for ideas, going back to the Ministry of Health and saying, okay, so we have a good start here, but it's not enough. We can't just develop teams. We have to develop systems that are focused on the critical issues and are supporting people to make this happen in a more systematic way. So we're developing not only frontline staff, but executive sponsors, leaders, creating resources that are going to support the system as a whole as we try to create this new vision of what's really possible to serve the people that we serve in our healthcare systems. Thanks very much.
Well, thank you, Ross. How many of you, this has really struck a chord with me, the real life example about form changes. Doesn't that hit home? It's just so real. So Ross started out with I think a bold statement which we all endorse: status quo is not an option. And it's very simple to say that, and very simple, I think, as you said to us, it's easy to agree that change is necessary, and it's maybe even easy-ish to outline a strategy, but it's the execution is where we struggle, and we find that's very difficult. Look, my take on this today was across all of the aspects that you covered, Ross, about cultural determination and change is important, about who we are and what we are, and understanding that probably is more important than most of us probably give credit to. Particularly also about what do the leadership, what do they display, what do they encourage. I love that the currency of leadership is attention. You're quite. I can see the meaning behind it very much so. And that we need to sponsor the resources. We need to have sponsorship. We need to have data examination. The messages you gave us there were many of them, and we will be all the better for it. It just goes now for me to thank our rockstar, Ross, and thank you, and I'd ask, ladies and gentlemen, just to thank Ross once again. See, there's just a wee bit of quality improvement. You noticed that earlier on I had to walk all the way over there to get it. Plan, do, study, act. Thank you very much.